Hi, everyone. Welcome back from the break. We're in the home stretch now, and you're definitely going to want to hang out for these last couple of sessions. We've got some really great stuff coming up. Now, we'll be starting with session 6, Innovations in Advancing Disability Inclusion in Medical Education. I'd like to introduce our moderator, Dr. Lucia McGeehan. She is a manager of examinee accommodations with the National Board of Medical Examiners. Dr. McGeehan?
Hi, thank you so much. It's an honor to be here with you all today. My name is Dr. Lucia McGeehan. I'm the manager of examinee accommodations in the Disability Services Unit at the National Board of Medical Examiners, and I'm truly grateful to be able to moderate this session. I have the pleasure of introducing our first speaker, Chris Skovira. Is a fourth-year medical student at Michigan State University College of Human Medicine, and their presentation is titled How Provider Perceptions of Disability Shape Clinical Decision Making, a case-based study of medical students, residents, and faculty.
Thank you so much, Dr. McGeehan. It's so wonderful to be here with you today. As the team shared, my name is Chris Skovira. I use they, she pronouns. I am a Caucasian, assigned female at birth presenter. I'm sitting in front of my bookshelf. I'm wearing a blue shirt in celebration of spring coming. And I myself am about 2 weeks away from graduating from medical school. And I wanted to thank the event organizers and all of the teams presenting here today. This conference has been really personally meaningful for me across all my years of training and really personally motivating. So thank you. So excited to represent my team here today and go through our work. So as mentioned, we looked into how perceptions of disability shape clinical decision-making. You should be seeing my slides now on the screen. We used a case-based study of medical trainees and physicians. So, okay, in the United States, 1 out of 4 adults have a disability, and about 15% of US adults have a mobility disability specifically. So what this means for us is that statistically, all or nearly all physicians are going to interact with an individual with a disability and most likely a mobility disability. And yet these individuals are receiving suboptimal care. So this should horrify us that patients with disability receive less preventative care, right? Because we know what the downstream effects of that are. They also face worse outcomes for interventions. And I think that the statistic that Leah Smith shared during the presentation on intersectional experience of disabilities, that 4 out of 5 physicians believe that individuals with disability face worse quality of life, strikes true on one of the themes that we heard about, the why behind why these individuals receive worse care than their peers without disabilities. This is not just about lack of provider training and awareness and clinical setup and clinic equipment. It's also about attitudes and knowledge. And that's something that really struck us as a team. We wanted to dig into that. So we took a unique approach in 2 ways. First, our focus was unique. We wanted to look at how perceptions may or may not influence clinical decision-making for trainees and providers already in their practice. Our methodology was also unique. We used a case-based method to both indirectly and directly ask about perceptions and to link that to decision-making. So I'll explain a little bit more about that in a minute, but I wanted to just show on the screen, I have the screen showing our full research team. And we would love for you to reach out and collaborate with us. This is a super collaborative team. We span states, we span specialties, we span level of training, we span individuals with disabilities ourselves, we span individuals who research disability very deeply. So our methodology was to administer an anonymous survey to 1st to 4th year medical students at Michigan State University's College of Human Medicine MD program, as well as to medical residents in family medicine programs and family medicine attending physicians across the state of Michigan. Respondents were asked to review a clinical case and then to answer multiple choice and free response questions based on that case regarding the patient's complaints of acute low back pain and hypertension. And respondents were randomly assigned to either receive case A, where the patient had a bilateral below the knee amputation, or case B, where the patient was exactly the same, except they did not have a bilateral below the knee amputation. Importantly, no cause was given for the amputation or for the patient's low back pain. We did not describe functional limitations in detail. So for example, we did not say the patient cannot do X or Y. And we had several notes about the patient's lifestyle, so their food choices, their activity level, but they were at a high level and shared between the two cases. The patient's condition, their physical exam, and their chief complaints were intentionally designed so that respondents had to use their clinical judgment. So for example, when we asked the respondents what they would do about the patient's low back pain, they could choose between physical therapy, opioid medication, non-opioid medication, or heat and ice. And there are clinical guidelines where you could make an argument for each of these. You would use your clinical judgment to choose. So the way that we did this is we had a multiple choice question where we kind of forced the provider to pick their first step, their first priority, and then a free response question where we asked them to explain why they made that decision. And we then asked them how likely they thought the patient was to follow through with their recommendations. We asked the same questions for both acute back pain and hypertension, with different treatment options for hypertension. We also asked a question about what the biggest challenge that providers felt they would face in managing this patient's condition, and asked why in a free response. So where are we in terms of the study? We distributed and received the study from all of the groups I mentioned. We completed the quantitative statistics, and we used a structured methodology to build a code book. So we identified all of the themes and language used in the free response text, and we're currently coding to see if themes occurred, more frequently in the case with a disability than the case without a disability. So we're in the process of coding this week, which is exciting. For the data, we collected data from 146 individuals, so 118 medical students, 11 residents, and 15 physicians. And we have some of our demographics on the slide, just showing that a majority of our respondents were female, about 65%, about 30% were male, and the remainder did not disclose or other. Of the medical students, the majority were first-year medical students, about 40%, and then 15 to 25% were in each of the other years. Interestingly, the majority of respondents to our case, 83%, did not themselves identify as having a disability, and 53% did not interact consistently themselves with a family member, friend, colleague, patient, or community member with a mobility-related disability. So going through the results at just a high level, just to give kind of a teaser of this, when asked about interventions for acute low back pain, a majority of respondents were spread between heat, ice, PT, or a non-opioid medication. Interestingly, between the two cases, we did not have a statistically significant difference. We think this may be due to sample size because we were nearing significance, but we had relatively small sample sizes. But the rationale given for the clinical decision-making did differ between the two cases. And some of the rationale was positive, but some of it was based on inaccurate assumptions about individuals with disabilities. So for example, we gave no reason for the patient's acute low back pain, but it was often attributed to the patient's posture in their wheelchair, or their amputation, or their lack of activity or exercise.
Chris, I do just want to give you a 1-minute warning.
Sounds good. There was also one thought about, a patient must already be on opioids if they have an amputation, although we had made no mention of opioids. In hypertension management, we saw this same theme of exercise is limited due to the amputation, although we noted that the patient completed exercise each week. And that changed people's decision. They did not pick physical therapy because they thought the patient could not exercise with an amputation. This really struck us as one of the first studies we saw that attempted to really link perceptions with clinical decision making and tease out perceptions indirectly. We think this truly illustrates a gap that's been identified in some of the innovations we heard in medical education earlier today about knowledge and training for medical trainees. And the curricula really has to go beyond clinical guidelines to addressing medical bias and stigma and misconceptions, because these are what really erode trust and what studies show patients with disability they do pick up on, and these do influence their care outcomes. From here, we're hoping to expand to other states and expand our sample size. So we would love to collaborate, like I mentioned, and we're finishing our coding now. On the last slide, I'll just leave up for a moment. I have contact information for Dr. Laura Van Pembroek on our team at Rush University, as well as for myself at Michigan State. So my email is skovirac@msu.edu, and we'd love to hear from you. And hers is laura_Van Pembroek@rush.edu. Thank you so much. It was so wonderful to be with you today.
Thank you, Chris. Thank you for that really important presentation. That was wonderful. Thank you. I'm Lucia McGeehan again, the moderator of this session, and I have the pleasure of introducing our next speaker. Arezo Ahmadi is a child of deaf adults and second-year medical student at the University of California, San Francisco. And their presentation is exposing undergraduate medical learners to caring for deaf and hard of hearing patients. Review of a lecture-driven peer teaching curriculum and workshop.
Thank you so much for the introduction, Dr. McGeehan. I'm going to go ahead and share my screen. It's so wonderful to meet everyone here. I'm really excited to talk about what we've been doing over at UCSF. So just to repeat, our presentation today is called Exposing Undergraduate Medical Learners to Caring for Deaf and Hard of Hearing Patients. This is a review of a lecture-driven peer teaching curriculum and workshop. And I have no disclosures to report. So a little bit about me that's already been mentioned. I'm a CODA, a child of deaf adults from Fremont, California. Notably, we have a school for the deaf, one of two in the entire state. So I come from a really large deaf community, and I went to UCLA for my undergrad. I also have a colleague that is in my class and that has worked with me on this initiative. He's also a third-year medical student. His name is James, also a CODA. It was really great to work with him in this initiative, and just a little bit about his background, Chico State, and did his MPH at Yale. So a little bit of a background on deaf communities. Deaf patients make up a very large, underserved, and vulnerable population in this country. There's about 11 are deaf. And with this identity comes associations such as having poor health status, chronic illnesses, and decreased healthcare use compared to those with functional hearing. And some drivers of these disparities include having reduced language access via reduced, whether it's telehealth, video relay services, things like that, poor communication resource use, and cultural competence that doesn't exactly meet the marks yet in practices. And so essentially, what really drove our initiative that we're talking about today are that deaf and hard of hearing, DHH populations, are at an increased risk for poor health outcomes. And so for us, what really drove home this need to create a curriculum is this idea that anecdotally in the literature, we see that medical students don't feel prepared to work with DHH patients, and there is expressed interest about having education in the curriculum. And here at UCSF, as I mentioned, in the Bay Area in California, we have a large deaf population. And so we do run into deaf patients here and there, whether it's through our clinical experiences, rotations, things like that, but our students aren't feeling well prepared to meet their needs adequately. So we wanted to address this gap through our initiative. And currently, before we were thinking about what we wanted to do about this problem, we were trying to look and see if there were existing models that we could replicate. But there are truly few models for teaching medical students about how to take care of deaf and hard of hearing patients and what their health status looks like across the board. And so we were really entering this kind of new area to do work in. And so our goal, given the background, given the statistics, given what our students want, given what students across the country have expressed interest in, was to create an elective course for medical students that prepares them to work with DHH communities, and also create sort of a blueprint for other schools and other students to replicate as well, to spread this curriculum. So a little bit about our elective, some information. We had a 1-hour in-person session every week for 9 weeks, and we also had a Zoom option. We had a speaker session in the first half hour, and then that was followed by half hour of ASL teaching. So me and my colleague James, as CODAs, we taught ASL, and our curriculum was approved by deaf and hard of hearing ASL users. And this was also funded by the UCSF otolaryngology department. So they funded having lunch, they funded interpreters, they funded everything that we needed. And it was facilitated by James and myself, two UCSF medical students. And just about accessibility, we provided ASL interpreters as funded by the UCSF ENT department, unless a speaker desired to bring in their own personal interpreter. And some objectives that we had for the elective, we wanted to expose students to deaf culture and healthcare views that were held by members of the DHH community. We wanted to recognize how autism and ableism can affect DHH patients. We wanted to explore the setting of a patient visit. So we aim to have a simulated patient visit at the end of our elective with a deaf/hard of hearing individual, and exposing students to learn how to use an ASL interpreter, things like positioning, things like how to address them versus how to address the patient, learning about interpreter etiquette. And then we also wanted to practice culturally competent care with DHH patient populations. So the next screen that I'm about to show is our curriculum. So it might be kind of overwhelming. So I'm going to take some pieces of it to show you the different topics that we covered. We had an introduction to deaf culture. We talked about health policy, the ADA, intervention and state-funded social services. We talked about a global health perspective. We talked about pediatric otolaryngology and how that introduction to the healthcare system from newborn kind of impacts pediatric patients and families, interaction with healthcare and navigating a DHH identity. We also talked about language milestones for deaf children. Of course, a session on ASL interpreters in healthcare. We talked about how medical perspectives can impact education in deaf education, language deprivation for deaf children, and how that affects adverse childhood events. And then we ended the elective with a deaf standardized patient integration workshop where we had simulated patients, we had interpreters, and we allowed students to use the ASL that we taught throughout the curriculum in a patient visit. And then for speakers, this is also one of those heavy slides, but just to give you an idea of the kind of speakers that we had for every session. We had a deaf professor from UCLA, we had a deaf lawyer, a deaf associate professor who does global health research, we had a pediatric otolaryngologist from UCSF, we had a fourth-year medical student who has done a lot of research in this space come and talk about her experiences. We had some folks who are deaf from the state's Department of Education. We had a pediatric audiologist who knows ASL, and we also had, who is part of our initiative, Dr. Spellin. She is a professor from Boston Medical Center, talk about her experience with working with pediatric DHH populations.
Arezo, I just want to give you a 1-minute warning.
Okay, thank you. So like I said, we had a final elective session that was about simulating patient visits, and the goal was to have students figure out the diagnosis while practicing culturally competent care. And we prepared background information like a door note, and we had interpreters at the session as well. With our outcomes, we saw that our medical students felt very prepared just seeing their improvement in ASL. They felt that they were exposed to deaf culture. They felt confident with taking a patient history with someone who is DHH and using interpreter services. And you can see that 61.5% of students felt that they felt familiar with video relay services, and students felt somewhat comfortable with using those services, but there is room for improvement, of course, and this is where we could see future initiatives really focus on. So overall takeaways of our curriculum, we incorporated lived experiences of DHH individuals and improved in participants' exposure to DHH culture and comfort with history taking. But we could see that in future initiatives could kind of integrate this curriculum and really expand it to bring more comfort for medical students to work with DHH populations. Thank you so much. This is my email. If you want to contact us, we would love to continue this space and curriculum. Thank you.
Thank you, Arezo. That was wonderful. And any questions that you have for Arezo, please enter it into Slido and we'll be sure to get to those questions later. I have the pleasure of introducing our next speaker, Dr. Andrea Lendaris, who is an assistant professor of neurology at the Icahn School of Medicine at Mount Sinai and a stroke neurologist. And they will be presenting the following: Adaptive Success in Action, Using Simulation to Transform Disability Education in Healthcare.
Thank you so much for the warm introduction, and thank you for the opportunity for sharing the work here. I do find this gathering of people just to be so meaningful and uplifting. Let me just pull up my slides. Great. Thank you for your patience. So yes, thank you for the warm introduction. I will also share that I identify as a physician with disability. I have Usher syndrome, which is vision and hearing impairments from birth. And excited to share with you what we did to meet many of the needs that many of you are discussing about medical education and needing an inclusive education to fill in our competent workforce. So the background, I know I'm speaking to this audience, many of you already mentioned that we know about the persistent healthcare inequities for people with and persons with disabilities. And that's true for our patients as well as us providers who are providing this care. There are training gaps in communication and accommodations to meet accessibility requirements. And embedded in the clinical environment is ableism, whether it's from the physical spaces or our workflows or how we interface and communicate with each other. So we know specifically within medical education, this gap is permanent and prevalent. There's limited training in disability competent care. And people often feel a discomfort in discussing disability with people who have them. Little preparation is given to professional support and development to work with colleagues who share disabilities. And so we need an education and we need tools to engage in inclusive ways and in a positive light. So we set forth on this mission locally. If you see in the lower left-hand corner, there's Dr. Matthew Swan. He's the director of the neurology clerkship that I closely work with. And we brought to the table the simulation director at our medical school, the director of the disabilities office, and the director of the professional learning and medical education. I'm just going to take a pause. I'm sorry. I forgot to give a visual description of myself. I'm a Caucasian woman who has brown eyes and brown long wavy hair. I'm wearing a black silk blouse and I'm wearing black cat-eye framed eyeglasses. So when this group came together, we set on some learning goals. We wanted to improve disability inclusive communication for the medical students. We wanted to help them recognize structural and attitudinal barriers. And we wanted them to develop adaptive clinical problem solving skills as opposed to a one-size-fits-all action item. Our innovation involved a clerkship level required curriculum. So for those of you who don't know, in the third year of medical school, students will rotate through different subspecialties. And so they all will rotate eventually through a neurology clerkship. And so we will capture all medical students in that year. We initiated this in 2024, and it's ongoing on a cyclical basis. There's 3 components to it. There's an observational piece, an experiential piece, and a team-based learning component. And we really sought out to focus on centering this for adaptive success and inclusion. The curriculum design starts with an email introduction from myself and from my counterpart, Dr. Swan. We set the tone, we share our personal experiences and intent in creating this curriculum, including myself as a lived person and physician with disability. Dr. Swan is a parent of a neurodivergent child, and so we already tried to set up the open culture there. We invite students to come and share with us if they are triggered or need support and anticipatory guidance for the workshop when we come together. Students do some asynchronous work and they prepare and learn about the models of disability, observation, and immersive. And then we come together for an immersive team-based activities along with structured reflections and debrief, and we capture some pre and post survey data. So the students work and they look at publicly available YouTube videos. We guide them to the social and medical model of disability to review, along with a video that has highlighted 3 physicians who are practicing with disability: a woman who's deaf, a man who's blind, and a man who had a spinal cord injury and operates using a wheelchair. Students also read articles about the social and medical model of disability, communication, and accommodations. And then we set them up with weekly prompts to guide observations. So the workshop comes together on week 3, but in week 1, we'll prompt them to start observing about disabilities and barriers in their clinical environments. The second week to try and identify the accommodations and adaptations that they see and if they're successful and who's supporting them. And then they share their comments on a shared anonymous platform. So then we come together in person for these team-based activities. And the first one is one of my favorite, the magic carpet. And here we give them a simulation where we change their vision, hearing, or movement, and they work together to flip the carpet that they're standing on. And it really sets up an improv kind of situation where they have to in real time adapt and collaborate and work together on a team building skill. So how do we set this up? So we have bought swim goggles that have field cuts that we've just created with painting in areas, setting up some rounded central vision, a full loss of vision with sleep mask, and then using weights to mimic asymmetric movement by putting them on their arms and legs, restricting back bands to restrict back movement, and then earplugs and headphones for hearing. And then we give them an adaptive tool to put in the mix of just seeing if they actually learn to shift and use it. This is just an image of them coming together to perform this activity. You can see them closely communicating with each other. And then the other activity is a Name That Tune, where we use popular culture songs, just using the background of the deep bass for them to identify it. We're having their hearing kind of having earplugs and noise canceling headphones. And here's just a screenshot of that. The students are standing and sitting around a table trying to, with their headphones on, listening to what the speaker is providing in the back. And so we sit together then and we debrief on these activities, a spontaneous conversation that comes from it. We reflect on those observations that we've prompted them to make, and we reflect on the social and medical model of disability. But more importantly, it all comes together in a capstone moment where they develop inclusive strategies and language to support accommodation and communicate about disability respectfully with their patients and each other. We've captured about 260 students in the pre-part of the survey, and 204 completed the post and the workshop. That attrition is due to religious holidays or people get ill, etc. I will walk you through this bar graph. On the left is the pre-assessment, on the right is the post. And essentially from 0 to 100% is the top of the bar graph. When we asked them if they understand the social and medical models of disability, that shifted from about 25% all the way up to 98%. Similarly, with their comfort with discussing disability goes from 54% up to 98%. Comfort discussing accommodations, 64% going up to 98%. Here, I think is interesting. While nearly all students, 97% of them, thought physicians with disabilities can practice and 99% afterwards. Not really a shift there that they have that belief. But when it comes to comfort in supporting colleagues, only 35% of them before the workshop really felt like they had a comfort in supporting a colleague, and afterwards, 99%.
Dr. Lendaris, you have about a minute left.
Thank you.
Yes.
Post-survey just further supported that nearly all students thought this would be clinically impactful and show patient outcomes, and overall rated the module good. I just wanted to pull out some themes here that came from a language model from their free text, that they all identified open communication and active listening as a meaningful output. And here's a student's quote to that end. In the interest of time, I won't read them. Second theme, individualized, patient-centered approaches to disability and accommodation, that we should have adaptation as a collaborative team-based process, awareness of structural barriers and non-visible disabilities, and the value of slowing down and allocating time to support inclusive care. The impact that we've learned is that it builds practical clinical skills, it promotes inclusive professional culture. It's feasible and it's scalable across medical education. We use it in this clerkship, but we also started to use it in residency and professional faculty development, as long as other staff members within our healthcare system. And so I'll just conclude there. Thank you for your attention. Please do reach out. Excited that we can share this at our medical school. Happy to collaborate with others and think about how we can link arms in this time where we really need to continue moving momentum to be more inclusive.
Thank you so much, Dr. Lendaris. That was really insightful and creative, and I really appreciated that talk. So thank you. I have the pleasure of introducing our next speaker. Jess Salyers is an occupational therapist who teaches at Northern Arizona University, and their presentation is Cultivating Compassion, Communication, and Client-Centered Care Through Inclusive Interprofessional Education.
Thank you for the opportunity to be here with you today. It's a true privilege and an honor. My name is Jess. I am an occupational therapist, professor, and mom to a zebra, which may for some of you seem like an odd opener since we're meeting for the first time. I navigate life as an average-sized white female who has brown hair and green eyes. I like the feeling of a cool breeze on my face, the smell of freshly mowed grass, and I love the sound of hoofbeats. I am here today to talk about inclusive interprofessional education. Interprofessional education, or IPE activities, occur when students from at least two different disciplines learn from, with, and about each other. In healthcare education, there are many different IPE activities, and IPE education addresses 4 core competencies aimed to improve communication, teamwork, ethical decision-making, and roles. Every year where I work at Northern Arizona University at the Phoenix Biomed campus, many programs come together to host the AZ Summit. Last year, I became the planning chair for this event, and I had a vision to intentionally and inclusively create a new case with and about individuals who are far too often underserved and underdiagnosed. Individuals with Ehlers-Danlos syndrome, dysautonomia, and/or mast cell activation syndrome are often gaslit, stigmatized, and traumatized by healthcare providers. The zebra on this slide represents the EDS community, often unseen, misunderstood, but undeniably real. Zebras are often told that in order to belong, they need to blend in, ignore their differences, become something easier to understand. But zebras are never to disappear into the background. They are, by design, meant to dazzle. I leveraged my positionality as a professor and professional to engage a team who believed in this vision to create an inclusive IPE event so that future healthcare providers and leaders could learn about these not so rare conditions that can go undiagnosed for decades. I called upon esteemed colleagues from Arizona State University, the PA and PT programs at NAU, Dr. Emily Rich, an occupational therapist and researcher in Tucson, patients, as well as providers with personal positionalities. This event could not have launched without their hard work and also the dedication of 3 incredible second-year OT students in our hybrid program who worked on this redesign the entire semester. Every step of the redesign process included patience. AZ Summit quite sincerely would not have been possible without patients who donated their time and lived expertise. Patients, as well as providers with a personal positionality to the zebra community, helped us design this new case. They created customized pre-work for every program or profession that would be at the event, and patients served as part of our expert panel during the 4-hour in-person event in November. Arizona Summit had graduate level students from PA, PT, OT, counseling, and nursing. They completed a pre-event survey to gauge understanding of IPE competencies and baseline knowledge about EDS, POTS, and MCAS. They reviewed a resource from the Ehlers-Danlos Society that we provided them and watched the video that was made for them by a professional in this population. The new case was designed to facilitate awareness of EDS, POTS, and MCAS in a manner that supported students' confidence and knowledge when working in their teams. The case was also designed in such a way to expand to include other programs in future IPE events. In fact, that day, 4 athletics training students showed up to the event because they saw flyers around the campus, and we welcomed them in. On this slide, we see a mom holding a baby to represent the case of Emma, a mom with known EDS who, after having her baby, started having other symptoms. IPEC competencies grounded in social justice were carefully selected to move beyond the standard outcomes for communications, teamwork, ethics, and roles. This case hoped to foster awareness, empathy, compassion, and community. An overview of the schedule is provided on this slide, which included an icebreaker, watching the video of Emma at an appointment with her healthcare provider when she explained new symptoms and demonstrated symptoms of hypermobility. After watching the video, students worked together to develop a patient-centered care plan. A group debrief was led by Dr. Kat Savoya, an expert physical therapist. That day, there were 3 patients who served as experts on the panel, 2 providers with personal positionalities to the zebra community, as well as faculty from PA, PT, OT, pharmacy, and nursing. The event hosted 170 students from 5 professional programs. As facilitators, we observed the teamwork, communication, and shared roles as students worked on a patient-centered care plan and learned from the patient experts. My second-year OT students commented on the vibe and energy of this event compared to the event that they participated in just the year before. The event costs were minimal. Less than $450 for this 4-hour event was split between 3 of the NAU programs. But there were also important unexpected outcomes. One student shared with her program at the end of the semester that AZ Summit was the most impactful part of her education that fall. Several students have also come to understand or share that they have EDS. Students also took information back to their clinics where they work or volunteer, and clinicians have been connecting with us to learn more. Going into this event, I felt fear and uncertainty with how to approach my why as I introduced the new case and I shared my positionality, but I was cheered on, hugged, and offered support by faculty, students, and patients. I felt immense hope as I watched a room full of future providers leading with curiosity and wonder as they were discovering how to look for the stripes and listen for the hoofbeats. Zebras don't survive by becoming something else. They don't hide their stripes. They survive by staying together, distinct, aware, and connected. They don't need every creature around them to share their stripes to thrive in the same space. But there is something powerful about finding others who understand the language of your lines. That's what a herd can be. In this slide, I have a picture of zebras living among others, and I am hoping that those who are here today will join our zebra community, become a member of the herd to increase awareness, education, resources, and compassionate care. To help welcome you into the herd, I have shared 4 resources to support your journey. These hyperlinks will take you to the Interprofessional Education Collaborative to learn more about IPE, the Ehlers-Danlos Echo homepage, as well as Dysautonomia and Mast Cell Disease Society homepages. As I conclude this presentation, I want to acknowledge all of our helpers, especially Alina, Jackie, and Shaylee from NAU's OT program, and Taylor, Victoria, and Deborah, the 2025 AZ Summit patient experts. And I also want to thank my daughter, who gave me permission to share her story at AZ Summit and reference her in this presentation today. Please stay in contact.
Thank you. Thank you, Dr. Salyers. That was very moving. Thank you. Hi, I'm Lucia McGeehan, the moderator of the session. I just wanted to circle back because I didn't have a chance to provide a physical description of myself. I have long brown hair, I'm wearing a blue cardigan, and I'm wearing black framed glasses. And now I really would like to open this opportunity up back to our panelists. I'm looking on Slido for any questions, and if none come in, I'm happy to ask some of my own. So I can ask a general one for the panelists, just any suggestions that you have, any additional suggestions, I should say, that you have for advancing disability inclusion in medical education?
I think, is it okay to just speak? I didn't know if you wanted us to raise our hands.
Oh, yeah, no, I think go for it.
Okay. I would say I think there's an ever more importance to support this work. It should go mentioning that within the last year, there's been great support for the residency program, the GME graduate level, where I think Lisa Meeks and her team and Docs with Disabilities have really worked to provide toolkits for those who are in leadership positions to really understand how to navigate and tailor people's accommodations to fit within the busy residency workflow. I think that's very important because some of it is just getting over the hump of how to meet the need. And so I've even, when I came across it, shared it, even though I'm not in one of those leadership roles, just to pass on the education. The American Academy of Neurology has also made statements in support of having physicians with disabilities in the space and working to better have care access barriers broken through, right? New York State has a law now. Not only do you have to ask, do you need an interpreter, but you have to ask about accessibility needs. And so I think that's a great step if we can keep supporting those efforts and really help deliver them more locally.
I think also thinking through, there's so many demands on training organizations around the amount of content that they have to expose learners to. So the work that people are doing today of gathering the data that proves how important this issue is and tying it directly to clinical care and clinical outcomes and what we all come back to of we want to make this better for patients, we want to reduce provider burnout, and better sustain our provider workforce. So I think tying to some of those key areas that are just very strategically important, and proving that with data is so helpful in terms of the proving we need a simulation on this in our curriculum.
For me, one of the things that's been really important is sharing my personal positionality and just creating this safe space for all learners and utilizing as much as I can, universal design, and also helping students navigate either the formal procedures within the university, helping them out in fieldwork or their clinical rotations, preparing for what to expect, but creating communities of kindness and acceptance within our program, and being very clear about my expectations for that, but modeling the way. And when students are going to, as we all will, make mistakes, and those are opportunities, and I'm very careful about how I call students in instead of call them out in those learning opportunities, because we're always growing and expanding, and I think that it's really important for all programs to consider that as easy. Like, that's such low-hanging fruit, but as presenters have mentioned time and time again, it does require a lot of reflexivity, I think, as a human.
If I could just add to that, I would say that I try to share with people that you're not going to get it perfect. I really like calling in, not calling out, right? It's not about knowing the answer. Medical school is very much, we got to know the answer. And having that pressure, I think just I walk around with my mobility cane in the hospital. I wear my hearing aids. I display it. I use a touch screen, right? Showing that there's a different way, doesn't have to be one way. And welcoming people into the conversation. I really like the term of universal. Like, I think if they say we have universal hand washing, we need universal communication. I start my rounds like on a Monday morning, like, please, these are my needs, share me yours. And if there's something that we need to have a conversation with, I invite you to participate in that. Engaging both as someone who feels like that you're not having your needs met, it's difficult to find that language. And maybe just developing that self-advocacy, it never goes away.
Great, thank you. I'm not seeing anything else on Slido, but again, I have some questions ready. I'll ask this for Arezo. She on? I'm not sure. Okay, that's okay. Jess, how does inclusive interprofessional education enhance communication and client-centered care skills?
That's such a good question. And I really had to consolidate what to prepare for this presentation, because there's a lot of well-established literature and studies that talk about IPE activities typically are not designed with patients. They are designed about. And so I think not all IPE activities will foster the same outcomes in that way of communication. But I think one of the things that really made this particular event unique was having so much representation. As you can, at the last slide was the picture of the hall. It was 170 students around the tables, and the panelists were asked, our expert patients were asked so many questions about what do they need from future providers, what has happened to them. And I think for providers to listen to, and for students to have the understanding of, you don't have to be the expert in this. The patient is the expert. There's just so much not understood about these conditions yet. Trust them, listen to them. I think that part of communication is often not really discussed or brought up, the importance of listening. But we do have good evidence that really does talk about, and really nice studies about inclusively designed IPE activities changing healthcare providers going forward to be on interprofessional teams, which include the patient.
Great, thank you. Thank you for sharing. Chris, how do provider perceptions of disability influence clinical decision-making? And what are the implications for patient care?
Studies have shown, and this was referenced in some of the prior talks as well, that there's an impact in if you have a misconception about the person in front of you, they are likely to pick up on that. So there can be a trust erosion with patients with disabilities when they don't feel seen or understood, and they may be less likely to seek future care after having an experience like that. So there's well-documented instances where, compared to peers without disabilities, individuals with disabilities are less likely to have follow-up care. They're less likely to go to specialist referrals. So it's kind of that snowballing effect that I referenced in the data that we've seen. In terms of how these perceptions influence clinical decision making, really that's what one of our key questions, and we're still kind of unraveling that. And it's complex. It's going to look different if we use a different disability in our case study, because there are different misconceptions across different chronic diseases and different disabilities. So it's a really wide and expansive impact that I think we're just starting to tap the surface on. And what we didn't look at in our study, but what I'm really personally interested in, is how those perceptions influence other providers who have either a visible or an invisible disability, because they're picking up on those too, right? So it's this ripple effect in our care teams and our care environments that touches patients and touches the care team. So bit of a broad answer, but I think it's just because there's, no one disability.
Thank you. That's very helpful. And I have one last question for Dr. Lendaris. How does simulation-based education transform disability awareness and ableism among healthcare learners?
Yeah, so thank you for asking the question, because you're also touching upon something that I wanted to bring up, which was that when we were preparing for this, we saw that there is a pitfall with simulation, and that classic simulation kind of can have the backfiring of just evoking pity and deficit-based experiences. And the example I could point to is if you say to somebody who's able-bodied, will get in a wheelchair and go to the cafeteria and get a cup of coffee. It's a known experience. They know how easy it may be in their own abled body. And so they're just going to comment on the physical barriers, perhaps the ableism in their communication. So we wanted to create it to be, this is an unknown experience. You don't have a bias as to what this should be like, this team-based puzzle making activity. But what do you do in the session? And it's really hard to capture that on the slides, because every group that comes through has a different dynamic. And we have different discussions based on their observations in the first 2 weeks and what they encountered trying to solve this puzzle. And an example I can give, one group put all the visually impaired people together and put them on one side of the carpet. And so we talked about that, like, well, why did you do that? And it was like, well, we wanted to protect them. And we wanted to take care of things, and then we were going to bring them in. And so then you get to ask the people who were visually impaired, simulated, for lack of a better word, well, how did you feel about that? Well, I just felt very passive. And I didn't think that I could be a part of it because I didn't see. I was like, okay. So you can unpack that conversation. Like, you're all the same classmates that just went through your clinical skills together. You all have the same abilities here. But do you see how you divide what your role can be in this community? And then they start unpacking that. And then you generalize it to the clinical environment and their observations. And so the goal is to really have them unpack those sorts of things. We do also see beautiful moments where someone discovers that that grabber we gave them is actually a key that could help you and the whole pseudo community. It helps you get the corner of the carpet to flip it over. And we kind of link that to the concept of curbside cutouts and how the disabilities movement started in the 70s, right? That when you give accommodation to one particular need in the community, the whole community can benefit. So we open their kind of perceptions and their minds to that. We like to think of it like focusing on the adaptation. So what did you do that worked? And how do we carry that out? We walk away with things. Many of these students were, what do I say to a patient? Say, what else can I do to help you? Can you hear me okay? Can you see me okay? What's your understanding about what's happening? And those open-ended questions and those postures a lot of them are looking for the language. And so we use what comes up in these simulation activities to try and give them those language toolkits. And many of them have been impressing us with things that they've done in the clinical space to help foster accessibility. So that's just a small group example, but that's certainly some of the work that we're doing.
Thank you. And I just want to thank all of the panelists. All of your presentations were wonderful. Thank you so much. And I'm just very grateful to have been able to introduce you. So thank you.